the prostate gland, when it's still in place, can alter urinary flow. It can enlarge for benign purposes over time. So you can have an enlarged prostate and prostate cancer, or you can have just, malignant enlargement, from aggressive prostate cancer that compresses and restricts the urine flow. So all of these treatments, whether it's prostatectomy, whether it's benign surgery for prostate enlargement, or radiation, can impact all of these different control valves or mechanisms. So here, it's a busy slide, but it's just important to realize and kind of understand that there is truly a brain to bladder connection, right? You get nerve signals from the brain coming through the spinal cord and to the bladder through a complex network of nerves. All right. And then the bladder itself provides feedback and kind of a signal back to the spinal cord that can alter the different signals that are propagated to allow the bladder to expand and store urine. The goal is to store urine at a low pressure. And then as the bladder fills, then the brain sends signals down for the various valves or sphincter mechanisms to relax as the bladder squeezes. Some of these pathways can be altered either surgically at the level of the urinary tract or outside of the urinary tract by injury, whether it's a trauma or radical resection of either the prostate, the bladder, or other organs such as the colon in the setting of colorectal cancer. So all of these interventions can disrupt proper signals that come down to the bladder. Specifically, when these signals are disrupted, then you can have various types of urinary incontinence. So, there you see just a very kind of simple summary of what these types of incontinence may be. Stress incontinence is a consequence of increased abdominal pressure that overwhelms the pelvic floor, the sphincter muscles that are holding the urine back, right? Whereas urgency incontinence is due to involuntary contractions of the bladder muscles that are either, kind of initiate at the bladder itself or a consequence of unchecked signals further upstream at the level of the brain or spinal cord, okay? Whereas overflow incontinence is what happens if the bladder just fills and fills and fills, but there's blockage downstream that's keeping it from emptying, or there is a lack of a signal that is encouraging the bladder to squeeze in order to empty. So then the urine sort of spills out of the bladder like overflowing a glass that's being filled. Okay. And then neurogenic incontinence is usually specifically related to some sort of condition, whether it's, what neurogenic conditions do is they interrupt the signals anywhere from the brain all the way to the level of the bladder. So if you've had a stroke, if you have MS, Parkinson's, different conditions can impact the signals that come down from the brain to the bladder. So other factors that can impact male continence or can lead to male incontinence are, untreated urinary urgency, so that have to go sensation, bladder infection, so cystitis, and then functional impairment. So if you have trouble getting around and you get a sudden urge to void and you can't spring out of your chair like you used to, before surgery, or even when you were a younger person, then the impulse may overwhelm the bladder and impact, and that could lead to urinary incontinence. So other conditions, like I had mentioned, neurologic disorders, congenital defects, those are lesions that people are born with, so spinal irregularities, and then of course trauma and peripheral damage to those nerves and structures. So when somebody, and I'll address the questions in the chat, I'll go back to review, but when somebody is impacted by incontinence, having lifestyle alterations related to leakage of urine, then they'll either address it through their primary care physician, and that'll turn into a urology consult, or they may have a urologist that they already see, whether it's the person that treated their prostate cancer or not. Sometimes patients follow up with just a general urologist because they've been seeing that person for a long time, and then they see their cancer surgeon specifically to address their cancer needs, or they may get referred to a subspecialist within urology like myself to evaluate and treat some of these disorders. When I see patients in the office, I do a comprehensive assessment to get an idea of the extent and degree of bother of the incontinence. So that means, history and physical, kind of getting the full story, what provokes the leakage, how many pads per day, if the patient's incontinent and uses pads, are they going through one thin pad or one big, chunky pad, or multiple pads, or some patients will wear a diaper and then put a pad on the inside as a liner. How many of those are getting saturated, and to what degree? Certainly we could get objective measurements such as weighing the pads. I find that messy and unhygienic. So I like to do a more kind of more objective assessment at the time of evaluation, because by the time they come to see me, they're already contemplating some sort of surgical treatment for urinary incontinence. Keep in mind that most of the time when prostate cancer survivors are having incontinence, it's almost always a structural problem, whether, if they had their prostate cancer removed, if they had a prostatectomy, or if they had radiation therapy. Those sphincter mechanisms can also become stiff, and patients can leak as a result of coughing, sneezing, bending. So those are all the details that I like to tease out in that initial evaluation. Do you leak with coughing, bending, working out in the yard, or do you leak with a sudden urge that overwhelms you? I mean, that's the balance there. Is it pure stress urinary incontinence? Is it urgency incontinence, or is it a touch of both? Okay. And once we go down that path, then additional evaluations that we may undertake would be, if somebody has had a surgical treatment for their prostate, then I like to look inside with a camera, do a cystoscopy in the office. It's a flexible endoscopy where we look at the urethra, we look at the prostate if it's still there, or we look at the transition between the prostate and the urethra to look for scars, to look at the quality of the tissue. We look around in the bladder itself, just looking for foreign bodies, whether it's people can have surgical clips or stones develop after prostatectomy. They become exposed in the urinary tract. And I just try to get an objective, just a peek at the bladder to see if it looks healthy enough. Sometimes it can look like it's overworked or overstretched. And if I have a reason to suspect some sort of bladder decompensation based on the visual appearance, then I may choose to do another more objective functional study, like a urodynamic test. That's sort of like an EKG for your bladder, if you will. It gives us information about how well the bladder stores and whether it squeezes well enough to empty or not. The endoscopy is also helpful if a patient has had prior surgical treatment for their incontinence and they're seeing need to address a failure related to that. All right, let's see here. So this is just sort of a review of prostate anatomy. I'll skim through most of this, but just a reminder, like I said, that the prostate sits below the bladder, and the urethra actually transitions into the prostatic urethra, and then the external urethra that we void through as it leaves the pelvis and courses through the perineum area, that bicycle seat area, and then into the penis. Okay. There are various types of treatments for benign prostatic enlargement as well. Some of you may have had a resection of the prostate, or vaporization of the prostate or some other endoscopic treatment for enlargement, benign enlargement, and then have come to find out after the fact or years down the road that you also had prostate cancer. So these are all different options for treating the prostate, and almost all of them are endoscopic. Okay. Um, just review some of the newer minimally invasive options that are out there beyond the kind of the tried and true transurethral resection or Roto-Rooter, as it used to be affectionately called. Nowadays in the office, we can shrink the prostate tissue by injecting it with steam. So if somebody has benign prostatic enlargement, we can do a procedure under sedation in the office and inject the prostate with steam to encourage the prostate to shrink over time. Many may have heard of the UroLift, which is sort of a mechanical parting or separation of the obstructing prostate lobes. For lack of a better comparison, you're just kind of stapling or clipping the prostate to the side to relieve any sort of obstruction. It doesn't actually get rid of any tissue, though. The tissue remains in this foreign body, is left behind, which, most of the time is good, but sometimes can have additional consequences. Some of the newer technology, there's aquablation of the prostate, and that's kind of a newer modality where we use planning. We use kind of a robotic platform with software to specifically tailor the prostate treatment according to your own prostate anatomy. So this is a procedure that's done under general anesthesia using a transrectal ultrasound, and then the image is uploaded by the software, and then we can specifically target different regions of the prostate for treatment. And the way that it treats the obstructing prostate tissue is with a pressurized water jet. So we're pressurizing or pressure washing your prostate to relieve the obstruction. And then, of course, there's resection type procedures, removing, massively enlarged prostates. That's a robotic simple prostatectomy. But many of you here are prostate cancer survivors, having had a prostatectomy. That's an actual surgical removal of the prostate for prostate cancer purposes. And here, what we see in this layout, this I mean, these are representative images of what it looks like in the operating room. There's a surgical assistant or another physician or a physician provider, at the bedside, and then the surgeon sits at a console next to the surgical bed. And the robot, essentially does what we do at the level of the console. However, we turn our hands and articulate our fingers, that those moves are replicated internally using laparoscopic surgery. Here, this other diagram just shows kind of what it looks like as the prostate is divided from the bladder neck. You see this network of nerves and blood vessels on either side of the prostate. And then you appreciate them here as well. There's not a specific named nerve that is always identifiable, and that's something that I think is important for prostate cancer survivors to understand, especially when they're confused or they're sharing that they were told that they had a nerve sparing procedure. I mean, I don't think any prostate cancer surgeon just starts out with intent of not sparing anything. I think even trying to spare the nerves kind of gets the surgery started within the right boundaries or parameters. Now, whether one nerve bundle is compromised versus the other just depends on the aggressiveness of the prostate cancer, not necessarily related to careless technique or anything of the sort, right? But we do, attempt to spare the nerves because the nerves sparing the nerves can be beneficial in preserving both sexual function and urinary function. But, in spite of our best efforts, incontinence does happen after prostate treatment. 50 to 70% of patients post-prostatectomy will experience it, and pelvic floor rehabilitation, that's organized Kegel maneuvers, can restore some of the urinary control to the point where the long-term burden or prevalence is in the order of 10 to 20%. Being incontinent, as many of you might know, can lead to decrease in physical and social activity, isolation, withdrawal, and it's worth noting that most men after prostatectomy will regain continence by about a year, and beyond a year, it's less likely that you would see a continued improvement. So it's important to know and highlight that surgical treatments for dealing with urinary incontinence are highly effective, and if this is a problem that's impacting your quality of life, you should see somebody to talk about different treatment options. And I'll touch a little bit as to what's out there. Certainly the simplest solutions are the non-invasive ones, and some of these are only really viable early on while you're still recovering from surgery. Once the prostate is removed and the new connection between the bladder and the urethra is made, then there'll be a period where incontinence is typically more severe, and you can either entertain using absorbent pads or external collection devices such as condom catheters or penile clamps that restrict the leakage. Okay. And like I said, this is only meant to be a short-term solution for most, unless you're just not surgically fit for a more definitive treatment for incontinence, or the time is not right for treatment. A lot of patients will ask me about any minimally invasive procedures or injection procedures. Maybe their wife had an injection for incontinence that's called urethral bulking. And while urethral bulking is very, very effective for women, it's not great for men. It's just kind of the anatomy is different even after the prostate is removed, and outcomes are pretty poor. The reported cure rate ranges from 5 to 53%, high failure rate. So overall, not advisable at this time based on available technology and materials, but it is just something that we talk about for completeness sake. More commonly, male urethral slings have been in the market for a long time. There are two primary sling mechanisms on the market right now. One from Boston Scientific called the Advance XP sling, and then the other one is the Virtue sling from Coloplast. Slings are generally best for men with mild to moderate stress urinary incontinence that have not had radiation therapy and have good bladder contractility. So men that are not retaining urine, that have not had radiation, that have mild to moderate stress urinary incontinence. Um, this is just a schematic of what the Virtue sling looks like. Slings, what they do is they either compress or elevate the urethra or lengthen the urethra, and they're placed through an incision. Both of these slings are placed through an incision between the scrotum and the anus in that saddle area, the perineum, where you would, sit on a bicycle seat. So it's a vertical incision. That's where we see the urethra, and we can reposition it using synthetic mesh materials that we pass through incisions in the groin on the inside of the thigh. We can grab the sling and tension the sling to strap the urethra tight. Okay. Same concept for the Advance XP. The Advance XP is a simpler sling. It only has two arms. The Virtue has four arms. And the continence mechanism is through repositioning or lengthening of the urethra, and that's what contributes to its effect. So before we move on, so slings are good if you meet those criteria. Like I said, non-radiated, intact bladder function, mild to moderate urinary incontinence. It's what's called considered a passive continence device, meaning that you don't have to interface or interact with it to void, right? So what you get at the time of surgery is almost kind of immediate improvement, if not complete dryness after the procedure, but there's no getting better. So let's say you had moderate to severe incontinence, but only opted for a sling. The sling may make you better, but you may still leak a little bit, and that's not modifiable. That's it's a done deal, right? So the gold standard for treatment of all types of incontinence, mild, moderate, severe, is the artificial urinary sphincter. The artificial urinary sphincter is placed surgically. It's a three-component device comprised of a cuff that goes around the urethra. So also placed through an incision down in the perineum where the sling is placed, but we go all the way around the urethra. So we do have to make a space behind the urethra. That's kind of the rate limiting step of the procedure. That's where you could theoretically injure it. Fortunately, that's very rare. But what you do is you measure the circumference of the urethra and you pick a corresponding cuff off the shelf, right? So if you measure 4 centimeters, we pick a 4 centimeter cuff or maybe slightly larger. And the cuff goes around the urethra like a blood pressure cuff would go around your arm, right? The cuff is connected by tubing to a pump roughly the size of my pinky finger, or like the first two joints of my pinky finger, and about as wide. And the pump goes in the scrotum in front or between the testicles. And then the pump is connected by tubing to a balloon that goes underneath the abdominal wall layers or in the pelvis. And this whole system is filled with fluid, with saline, right? And what it does is once the device is activated, the cuff always closes around the urethra to compress the urethra. And when you're ready to void, when you feel the urge to go, then you reach down in and grab a hold of the pump and give it about 2-3 squeezes. And what it does is it relieves the kind of gets the fluid out of the cuff, allows the urine to come down, and then it'll automatically refill after a preset period of time. Okay. But because it's a mechanical device with connections and moving parts, it is subject to material fatigue or breakdown of the connections or both. The most devastating consequence of the artificial sphincter is if the sphincter becomes eroded into the urethra. So the cuff could work its way into the urethra where it becomes exposed with the urine, and then at that point it has to be removed, and some other reconstructive surgery needs to be undertaken. And then one of the newer options that's out there is a bit of a hybrid. It's the adjustable continence balloons, or ProAct balloons. These have been around in Europe for a long time, but only recently got approval and started gaining traction in the United States. And it is a passive continence device, meaning that you don't have to interact with it to operate it. Similar concept of urethral compression by balloons, but instead of having a balloon all the way around the urethra, you have two balloons that are inflated next to the urethra at the transition between the bladder and the urethra. So for lack of a better comparison, it almost recreates the prostate, right? The compression or impingement from the prostate, the balloons press the urethra to hold the urine back. Originally developed for use in females. The way that we place these are through two small, 1 to 1.5 centimeter incisions, also down in the perineum, the saddle area, right? But because the incisions are smaller, the recovery is typically more straightforward, though it is a very, very different skill set. Rather than visually kind of seeing specifically where we place the device, here we rely on X-ray guidance, right? To X-ray and dye in the urinary tract so that we can place the balloons in the right location where they're gonna stay and hopefully reduce the degree of incontinence. Now, the advantage of this particular approach compared to both the artificial sphincter and the sling is that these are adjustable, and they're adjustable because the balloons are connected by tubing to this metallic port here. And the metallic port has a hub that you can puncture with a needle to add or remove more fluid, right? So after we place the balloons, we actually kind of guide the hub to the backside of the scrotum here, and that's where we leave them, so that once a patient recovers from this surgery and is ready for an adjustment, you come back to the office and we can actually just put a needle in the scrotum into the hub and add or remove fluid. And that's a clinic procedure that takes 5 minutes or so. Okay. So here's just kind of a comparison of all the surgical modalities for treatment of stress urinary incontinence that are kind of a part of our toolkit right now. The PROACT, has been shown to be efficacious. I would say that the sling is just as efficacious as the PROACT. This is not my graphic; it's from one of my mentors, but I would say that they're just as efficacious. But truly, the artificial urinary sphincter is the gold standard, the most effective for all degrees of incontinence, mild, moderate, or severe. In terms of operative time or hospital stay, I mean, the PROACT can be a quicker procedure. I've done them in as short as 30 minutes, right? But I've had some tough ones that may take an hour, whereas a sling and an artificial sphincter may take an hour to an hour and a half. So slight advantage to the PROACT. In terms of reproducibility, the PROACT is the least reproducible, meaning that it really does kind of take some nuance, has certain nuances, and requires you to have a good understanding of the anatomy and kind of use your mind's eye to visualize where the balloons are going to end up. Okay. Whereas the sling and artificial sphincter it's very, very established. They've been around for decades. In terms of recovery, sling and sphincter are about the same. It's about a 4 to 6 week period of a post-surgical recovery. The PROACT may be a simpler recovery because the incisions are smaller, but the time necessary for activity restriction is the same. It's exactly the same as the sphincter, because if you get back on the golf course too soon, or trying to be too helpful at home after a PROACT, you can actually dislodge one of the balloons if you bear down and strain. They can pop out of position. We only put 1 milliliter of fluid in the balloon, so it's easy. I had a gentleman who did great initially after a PROACT, and then one of his doors at his house came off a hinge, and he just sort of lifted it to screw it back on, and that maneuver was enough to dislodge one of the balloons, and it was game over for him. We had to try again later. Okay. One of the real advantages of the PROACT and sling over the sphincter is that they don't require specific mind or physical skills, meaning that if somebody's memory is starting to lapse and they're starting to get confused about other things in life, we worry that less about them having a sling or a PROACT than we would about them having an artificial sphincter, because the sphincter does require that they kind of actively engage or participate with operating the device in order to urinate. And then in terms of rates of infection or erosion, fortunately, rates of infection are pretty low all across the board. I would say that I think the PROACT slightly higher risk of infection, in my opinion, because the device itself is not coated with an antibiotic solution, and then we're sort of poking at it as we're making adjustments. So theoretically, every time you introduce something external to it, you could cause an infection. In terms of mechanical failures, the artificial sphincter is the most at risk for it. If it does fail over time because of a connection or a pump issue, a replacement generally means that you're having a surgery, right? If the sling fails, you still need a surgery to do some other incontinence maneuver or procedure if the goal is still to be dry. The PROACT, the failure potential is there, but they can be more easily removed if they pop or get infected. Okay. So overall, I mean, I think both of these or all three are great treatment options. The question that you have to ask yourself is, do I want to interface with a device or not? But I think the most important question is, how bad is the incontinence? If you're wearing multiple diapers or pads, soaking through them in a 24-hour period, there's no doubt that the artificial urinary sphincter is superior. Before we wrap it up, I just want to touch about the other component in urinary control and incontinence, and that's urgency, unchecked urinary urgency. that's because of nerve dysfunction anywhere from the level of the brain through the spinal cord and then down to the level of the bladder. Usually would treat urinary frequency and urgency with medications for overactive bladder. The challenge is that the anticholinergics, the kind of the first line medications, have very profound side effects in older folks. Okay, they can lead to confusion. They can lead to other problems that are already going on, like dry mouth, constipation, dry eyes, etc. So they're not my preferred, they're not my go-to medication in older folks, but sometimes we're forced to do so by insurance because they won't cover the more selective medications, which are the beta-3 agonists that can control the frequency and the urgency. These are medications like mirabegron or vidbegron, Gemtesa, and they are less likely to have some of those very profound side effects. Now, if a patient fails or did not respond to medication or cannot tolerate a medication because of side effects, then there are kind of second and third line treatments for overactive bladder. Those could be bladder Botox injections directly into the muscle of the bladder to blunt the bladder impulses that are the nerve signals that are coming down to the bladder muscle. Similarly, we could do that using electrical stimulation. So some of you may have gone to your urologist and had peripheral nerve treatments, which is what you see here in this kind of top picture. It's where they put a little needle by your ankle and they stimulate the tibial nerve to almost to hotwire or to retrain the bladder impulses, right? The upside is that it's a relatively low risk, minimally invasive treatment. The downside is you have to go to the office, frequently for treatment, and then once you stop doing it, then the effects wear off, right? Whereas the more permanent solution to the bladder impulses is something like an implantable stimulator, sacral neuromodulation, which is almost like a pacemaker for your bladder, right? We place needles and electrodes at the backside here, the tailbone, and we can then use an electrical current to stimulate the bladder nerves continuously to retrain or reset the bladder impulses. I personally do this in a two-stage maneuver. With the first stage, I just place the electrodes and I connect them temporarily to an external device that cycles through different programs or stimulation settings. And if a patient improves by at least 50% in terms of their urinary frequency and urgency, then I go through with the second stage, which is to get rid of anything that's external and connect it to an internal battery that's implanted underneath the skin at your backside. So that's all that I have. I mean, I think it's just important to know that normal urinary function is a fine balance between nerve and physiologic functions, and that surgical treatments for urinary incontinence, for stress urinary incontinence, are highly effective. But you should talk to somebody that has experience with these treatments to make sure that you pick the right therapy that's for you. Okay, so I'm gonna look at the chat real quick. And I'm happy to answer. Let me see here. I believe they got it recording. Let me see here. What are the signs that a male's pelvic floor muscles are weak? Is there a litmus test? I mean, weak pelvic floor muscles are generally, in men, we see an expected weakness after the prostatectomy, after the prostate is removed. Then some of the nerve signals to the pelvic floor can be altered, as well as kind of just when a muscle stops receiving nerve stimulation, then the muscles can atrophy, right? So that's where early participation with the Kegel maneuvers, the squeezing and relaxing maneuvers, can be very, very effective in restoring urinary control. Okay. Let me see here. Clear telltale signs. Yeah, so I mean, it also just goes to the post-surgical recovery is tibial nerve stimulation. Generally effective. I mean, it's mixed. I have mixed success. I think if you have the time to devote to it and see some improvement, then I would encourage you to do it. But at some point, it's important to understand that once you stop showing up for the therapies, then you will revert back to your usual state, and that's where something that's more permanent, more portable, may be more effective. Okay. What would follow after if a nerve bundle is compromised as a result of surgical or other treatments? How high is the incidence of this occurrence? Uh, so there are no red light or other natural pathways of coping with this. I mean, I think keep in mind that a lot of these therapies that you might read about, they're not studied at a high level. They may be looking to take advantage of a vulnerable patient population that's already suffering enough from prostate cancer treatment. I would say that if, the incontinence after prostatectomy is kind of expected. The prevalence that was at the beginning of the talk is 10 to 20% after treatment. So most men will recover the majority of the urinary control within a year of their prostatectomy. Let's see here. If prostate is removed with sexual intercourse, can you talk about the common and uncommon changes that one would expect to result other than lack of ejaculation and what those probabilities are? Do the overwhelming majority still have ability to experience pleasure? So yeah, I mean, I think with climax after having had a prostatectomy, you won't have the release of the ejaculate. So a lot of the sort of the erotic sensation of pleasure may come from the kind of feeling that release externally of the semen, but your climax should be preserved after prostatectomy. The difference is some men will leak a little urine with climax, so we call that climacturia. And if it's bothersome enough, we could also treat that like we would primary urinary incontinence after prostatectomy. After prostatectomy 3 months ago, still incontinence is severe. Yes, there's still a very good chance that it'll get better with PT and Kegels. I encourage aggressive, participation in those maneuvers to kind of put you over the edge to be on track to recover up to a year out from the prostatectomy. Severe incontinence besides pads, and so natural remedies. So I mean, the only natural remedy that's out there is avoiding things that may make your urinary function worse. So certain dietary modifications, avoiding spicy foods. If you eat spicy foods, it'll irritate the bladder. It'll make it, make you want to pee frequently and urgently. Carbonated beverages can also have similar effects. Coffee, etc. So if there's a leakage problem, then avoiding bladder irritants can reduce the frequency and the urgency that we may see, as you continue to recover from surgery. So prostatectomy 15 months ago, urinary leakage for 15 months, catheter was worse than the surgery. AUS procedure last week, and hope that this will solve. Yeah. I mean, I think artificial urinary sphincter is highly effective treatment once you know that things aren't getting better. And the earliest that I will treat surgically for stress urinary incontinence after prostatectomy is 6 months. Even though somebody still has a reasonable chance of getting better up to a year out, if they tell me like I'm miserable, I'm just not dancing, not seeing my grandkids, not golfing, I'm depressed, I smell terrible. I mean, those are all reasons why there's no sense in drawing it out and making you wait 6 months. If the incontinence is moderate to severe at 6 months, it's probably still going to be significant at 12 months. after TURPs, what's the incidence of incontinence? Fortunately, incontinence after TURP is a very rare. I can't give you a hard and fast percentage, but my experience with it is that it's quite rare that you would have stress urinary incontinence. It's important to remember. I think this picture of the boulder is important. That once you relieve the obstruction, then your bladder has been conditioned a certain way to kind of push through the obstruction. So once you relieve the obstruction, then some of the incontinence that you may see after an outlet procedure like a TURP is from the bladder and not necessarily from lack of a sphincter control, right? Um, uh, so yeah, I mean, I think I said this. How soon after prostatectomy? 6 months is my number. Is the artificial sphincter or nerve stimulation applicable to people who have had radiation? Absolutely. I mean, I would say that the majority of my sphincter patients have had some sort of pelvic radiation, right? Whether their prostate is still there or not, whether they had primary radiation therapy for prostate cancer and then develop urinary incontinence later, or had prostatectomy and then had salvage radiation therapy. And the reason they get sphincters is because we know that they just won't do well with a sling or the PROACT once they've been radiated. Let's see here. Up and coming changes with prostate treatments. Yeah, I mean, I think there are a lot of things out there. There's a lot of um, there's a lot of interest in focal therapies, ablations, whether it's, HIFU, cryoablation, or laser treatments. I mean, most of those are not ready for prime time, and kind of your candidacy for that needs to be carefully discussed with, the either your urologist that's referring you to somebody to do that, or whoever does that procedure. I'd be careful with making sure that whoever that individual may be is a reputable individual and not just looking to sell you something that may not be as good for you. How do you see diagnosis and treatments changing as AI continues to improve upon itself? I mean, I think I'm a big AI enthusiast, and I study it a lot for various reasons. But I don't know that AI is gonna be the answer that we're looking for all of these issues. I think AI may be helpful as a kind of in shared decision making, maybe helpful in summarizing these difficult discussions that we have with patients.
Infancy now, isn't it?
I mean, it's been around. It's just AI can hallucinate, right? It can interpret the wrong information. It can confabulates, can make up sources and facts. But I think the AI is just as good as the input that we give it. So we can train certain AI and certain models to account for some of these clinical concerns in helping patients make decisions. Is there a treatment for leaking after radiation for prostate cancer treatment? The answer is yes. It depends on frequency and urgency versus stress urinary incontinence versus both. And in my hands, it's typically the artificial sphincter, because men that have had radiation therapy typically don't do well with a sling or the adjustable balloon. And then the balloon therapies, will they interfere with other procedures like a penile implant? Typically not, because they're placed in a completely different neighborhood. And I tend to not do both of the procedures at the same time. I find that it just kind of draws out surgery, and I want one of those procedures to go really well rather than two to go, so, right? So for that reason, I tend to focus on the most distressing problem, in my opinion, and my experience in dealing with patients. That's typically the urine control, right? Because it's hard to get intimate if you're leaking and wet. 2 fractions of high dose radiation brachytherapy. I mean, that's a complicated scenario. I would encourage you to kind of see kind of a dedicated specialist within urology. So somebody like a reconstructive urologist like myself, or there are a couple of us in the LA area. But I think that's warrants a very thorough evaluation, because after radiation therapy, the challenges that I encounter as a reconstructive urologist is men have leakage because of impaired sphincter, bladder function, or both, but they may also have scarring of the urinary tract, whether it's a stricture or a scar of the urethra downstream from the prostate, or where the prostate used to be, or at the previous transition of the bladder to the urethra. So that's a much more complicated scenario. Sometimes you have to deal with the blockages first and then move on to dealing with the incontinence. And dealing with the incontinence after those reconstructive surgeries is not straightforward. Let's see, touch base as to why it takes almost a year longer. I mean, I think that's also very complicated. It just depends on whether the intent of the surgery was to I mean, like I said, we always set out trying to spare the nerves, but some patients aren't candidates for nerve sparing based on their cancer situation. If they have extensive, prostate cancer on both sides of the prostate that is high grade, sparing the nerves is going to be a lower priority, because at the end of the day, it's still a cancer surgery, right? We don't want to leave any cancer behind.
How about Lupron?
Lupron, that's an excellent question. So there is evidence that the atrophy, the kind of the wasting of the urethra that happens in the castrate state from having had Lupron or similar therapies can compromise the healthiness of the urethral tissue. So I do find that patients that were previously continent may develop incontinence once they start their androgen deprivation therapy, or patients that had prior surgical treatment, like let's say a sphincter, may have urethral atrophy to where like the sphincter won't fit the circumference of their urethra as well, as a consequence of the therapy. Okay. Warm pads, baths, no specific details or evidence to support any of that. See, prostatectomy, radiation cystitis, thoughts on hyperbarics to mitigate. Yeah, absolutely. If the hyperbarics can get approved, then I'm a big supporter in hyperbarics for radiation cystitis, or prior to any sort of reconstructive surgery, by kind of improving the healthiness and the blood flow to the tissue. Problem with radiation and PROACT. Yeah, so that's an excellent question. When I adopted PROACT as a therapy, and I'm one of like a handful of urologists in the LA area that do it, I was one of the early adopters, right? And the reason that I used it is because there were men that were either sphincter candidates or sling candidates, but there was no option for in between. If you'd had radiation, or if you were the guy that needed a sphincter but just wasn't there physically or mentally to have one, right? So that's why I started doing the PROACT. And I think the way that I started doing PROACT was the wrong way. I started using it in my most challenging patients. So the post-radiation, post-reconstructive surgery, not a good candidate for anything, right? And what I found was that the outcomes, the improvements in those men were a lot less than when I started using PROACT for men that had not been radiated, that generally had mild to moderate incontinence. And that, I think, is related to two things. Once you've been radiated, the compressibility of the tissue at the level of the bladder neck and the urethra is lower. So kind of the compressive effects of the balloons are, maybe less effective. But also, once you've been radiated, the bladder stretchiness, the compliance, and contraction, it changes to the point where a lot of the times the incontinence is a factor of just a poor bladder function itself rather than a sphincter problem alone. Let's see, last couple of questions here. Identical twin, PSA is 3. I can't really speak to that. Acupuncture does not help for stress urinary incontinence, and could be beneficial for frequency and urgency, but we've got our own homologue to acupuncture. I can't really speak to CyberKnife compared to standard radiation therapy. It's a more it's a more precise treatment, but I think kind of the decision to undertake any of that just depends on individual cancer details that I'm not privy to. The Lupron, yeah. So Lupron, once again, low testosterone state. There's less blood flow and there's atrophy of the urethra. So, I mean, some men will report shrinking of the penis while they've been on androgen deprivation therapy. So, if you have atrophy of the genitals, which include the urethra that courses through the genitals, then some men can develop new incontinence after they start their Lupron. Or if they've had surgical treatment for incontinence, they can get recurrence or worsening control once they start using hormone therapy. Let's see. Preventing. So, preventing infection when self-catheterizing. That's also kind of like a individual concern. I mean, I think proper self-catheterization technique is important. It doesn't have to be absolutely sterile, but clean intermittent catheterization is fine, and it doesn't necessarily translate to an infection per se, but rather just a urinary tract colonization. So I think these are all excellent questions. Thanks for showing up. And then great virtual turnout with a good Q&A. So I think we'll see what we can do about sharing the slides. But I encourage you to kind of reach out to either your individual urologist, or if